Cascade of TB case finding and TPD. Algorithm for contact screening and screening of HIV negative or unknown less than 15-year child for TB. Identification of an index pulmonary TB case. Trace for child who is household or close contact of the index case. When the index TB case has direct susceptible TB, well child symptom consistent with active TB, provide TPT, evaluate for TB, symptom resolved, no TB. If TB, treat for active TB. On the right side, when the index TB case has a risk factor for or confirmed drug resistant TB case, well child symptom consistent with active TB, quarterly clinical monitoring for possible development of active TBDs for 2 years. Evaluate for DR TB. TB preventive treatment option. Currently, recommended TB preventive treatment regimen include 3-HP or isoniazid plus rifampicin weekly for 3 months. 3-RH or rifampicin plus INH daily for 3 months. 6H or 9H, that means isoniazid or INH daily for 62 or 9 months. 4R means rifampicin daily for 4 months. 1HP or isoniazid or INH plus rifampicin daily for 1 month. 1. Isoniazid preventive therapy or IPT. The most commonly used preventive treatment for latent TB infection worldwide. Evidence showed IPT has been effective to reduce the risk of reactivation of TB by 60 up to 90% among high-risk groups. Minimum of 6 months, but usually 9 or 12 months. Safe with most ART regimens. Challenges for scale-up. Low uptake, longer regimen. Side effect, problems with adherence and poor completion rate. Challenges for the programs or systems. 2. 3 months of daily rifampicin and INH or isoniazid, that means 3RH. Combination of rifampicin, symbol R, and isoniazid, symbol H, administered daily for 3 months. Efficacy is equivalent to 6H. Advantage: cheap availability of child-friendly formulation, less toxicity. Disadvantages: DDI with ARVs. 3RH has preventive treatment requires same dosing as recommended for treatment of drug-sensitive TB. What is 3HP? 3HP means it is short course TB preventive therapy or TB regimen, which is endorsed by the WHO, World Health Organization. Combination of high dose of isoniazid and rifampicin administered once weekly for 12 weeks or 3 months duration. 3 months of weekly INH and rifampicin, that means 3 HP. Combination of high dose of isoniazid H and rifampicin P administered once weekly for 12 weeks or 3 months duration, non-inferior to isoniazid monotherapy in preventing TB disease, simpler, shorter, and requires few doses, that means 12 doses, improved adherence and treatment completion rates, significantly lower hepatotoxicity, can be safely co-administered with antiretroviral drugs such as efavirenz, DTG, and reltigravir. Less burden to healthy programs to implement. Limitations of 3-HP. Relatively expensive in comparison to other TPT regimen. Current cost 15 or 15 US dollar for full course. Rifampicin for adults cannot be used for children less than 2 years as proper dosage is not yet known. The drugs are available in loose form and no child-friendly formulation yet. Caution should be exercised in using 3-HP for pregnant women. Safety evaluation undergoing. Need to ensure use of barrier methods among women of childbearing age due to DTI with hormonal contraception. Comparing 3-HP, 3-HR, and 9-H for children under 50 years. Age. On the column age, horizontally 3-HP, 3-HR, 6H. Efficacy under age. 3-HP. The age is greater than or equals to 2 years. 3-HR, all children less than 15 years. 6H, all children less than 15 years. The same as 3HR and 6HR, same. Efficacy under 3-HP, non-inferior to 9H. Under 3HR, likely equivalent to 5 to 9H. Under 6H, greater than 60% reduction of TBDs in the following 2+ years. Completion rates. Under 3-HB, 88.1%. Under 3HR, 89.5%. Under 6H, 80.9% and 65.5%. Hepatotoxicity. Under 3-HP, none. Under 3HR, none. Under 6H, none. That means 1.2 up to 1.6%. A is under 3-HP 0.1 6%. That means G3 only. Under 3HR, none. 2 to 64%. Under 6H, 0.2% or G3 only. That means 1 point or 1 up to 24%. Number of doses under 3HP, 12 or once per week for 3 months. Under 3HR, 90 once daily for 3 months. Under 6H, 180 plus. That means once daily for at least 6 months. Algorithm for HIV negative and HIV exposed children less than 15 years of age with TB exposure. Children aged less than 15 years exposed to pulmonary TB or HIV negative unknown or HEI. Screen for active TB disease. On the left side, symptoms suggestive of TB present. Refer for hospitalization. Yes, any concern of severe illness. At least one symptom meets strict criteria. Under symptom suggestive of TB present, no symptoms not meet strict criteria. Refer for further diagnostic workup or gene expert or chest X-ray. TB diagnosis excluded. Treat as per IMCI guideline and follow after 2 weeks. Persistent physical signs or symptoms. Go on, screen for active TB. On the right side, no symptoms suggestive of TB present. TB diagnosis excluded. Start TPT. Then symptoms resolved. HIV exposed on NVP. Go on 6H per B6. HIV unexposed or exposed not on NVP less than 2 years or greater than 2 years. For less than 2 years, 3RH per B6. Less than or equals to 2 years, 3HP or 3RH per 6H. Poor weight gain, fever, current cough, household contact with pulmonary TB case. Can also consider loss of appetite, neck swelling, lethargy, fatigue, reduced playfulness with Note to the algorithm. Suspect pulmonary TB when with is asymmetrical, persistent, not responsive to bronchodilator therapy and associated with other typical feature of TB. Indication requiring hospitalization or referral. Severe form of pulmonary TB and extrapulmonary TB for further investigation and initial management. Severe malnutrition for nutritional rehabilitation. Signs of severe pneumonia, that means chest indrawing or respiratory distress. Other comorbidities, example severe anemia. Strict symptom criteria. Persistent, non-remitting cough or wheeze for more than 2 weeks, not responding to standard therapy. 2. Documented loss of weight or failure to thrive during the past 3 months, especially if not responding to food or and micronutrient supplementation or severe malnutrition. 3. Fatigue or reduced playfulness. 4. Persistent fever greater than 10 days. 2 or more of these symptoms are highly suggestive of TBDs. Summary of pediatric TPT options for HIV exposed and HIV positive children on antiretrovirals for prophylaxis or treatment. Household child TB contact less than 15 years, asymptomatic. 4.4 up to 9.9 kg or greater than 2 years, greater than 10 kg or kilogram, 2 years and up. HIV negative or HIV exposed, not on NVP. HIV positive on LPV or RDTG or NVP. HIV exposed on NVP PPX. HIV positive LVP per R NVP or DTG. HIV positive EFV. HIV negative, that means 3HP or 3RH. HIV positive on LPV per R, DTG or NVP, 3RH. HIV positive on LPV per R, DTG or NVP, 6H. HIV exposed on NVP, PPX, 6H. HIV positive LPV per R, NVP or DTG, 6H. TPT initiation and monitoring. Baseline assessment for TPT or 3HP. 1. Personal history of allergy to TB drugs, HIV, comorbidity, pregnancy. 2. Rule out active TB. 3. Assess potential contraindication. 4. Elicit medication history and assess drug interactions. 5. Consider baseline liver testing for at-risk individuals if indicated. 6. Initiate appropriate TPT and B6 for those at risk of peripheral neuropathy. Contraindication to TPT in children. Any liver damage, active hepatitis, ALT per AST greater than 3x ULN, even if asymptomatic, regular and heavy alcohol use, peripheral neuropathy, symptom numbness, burning, sharp pain, tingling of hands or feet, risks, diabetes, vitamin deficiency, and medications can cause PN. Baseline assessment, appropriate counseling of parents or caregivers before TPT initiation, rationale for TPT and the benefits to the individual, the household and the wider community. TPT being available free of charge through national programs. TPT regimen prescribed including the duration, direction for intake of medicine and follow-up schedule, potential side effects and adverse events involved, and what to do in the event of various side effects. The importance of completing the full course of TPT, reasons and the schedule of regular clinical and laboratory follow-up for treatment monitoring, sign and symptom of TB, and advice on steps if they develop them. Selection of TPT regimen, the factors that need to be considered during selection of the regimen for treatment of LTBI or latent TB infection. Age, less than 2 years and above. HIV status, HIV positive, HIV negative, HIV status unknown, HIV exposed. Drug-drug interactions, example ART regimen. NVP or PI based, vice versa, non-PI regimen, hormonal contraception, contraceptives, pregnancy or breastfeeding, availability of drugs,